Okay, so this is part two, picking up with ACS. So fibrinolytic therapy, 90-minute to door to balloon, is not an option. So this is dissolution of a clot by an enzyme such as streptokinase. So tissue plasminogen activator, known as TPA, is given 100 milligrams IV and it's infused over 3 hours. So some contraindications to this, CPR for greater than 10 minutes, active bleeding, or if the patient has had a recent hemorrhagic stroke. So the best marker of reperfusion is when you do the EKG and that ST segment has returned to the baseline. But the thing you have to keep in mind here, the major complication, obviously, is bleeding. So next we're going to talk about pain. So nitroglycerin, like I mentioned, it's every 5 minutes times 3 doses. Hold of systolic is less than 80. So typically, the patient, one of the main side effects, the patient will complain of a headache. So you just need to educate your patients to take some Tylenol. Also, they want to watch out for an expiration date on their nitroglycerin bottle. So how do you know when the nitroglycerin is effective? And that would be the patient has decreased chest pain. Make sure the patients store the medication in the dark container that it comes in. Nitroglycerin is sensitive to moisture and light, and it should be kept in the dark, airtight container. Morphine sulfate that I mentioned earlier, if nitroglycerin is not effective, typically the healthcare provider will order morphine sulfate for anginal pain and pain post-myocardial infarction, and that's because the medication decreases preload and it decreases afterload, and it dilates the coronary vessels. One of the side effects, of course, of these narcotics is constipation, so be aware of that. Other interventions, oxygen, continuous monitoring. The patient probably will be on telemetry. You have to watch out for tachycardia. PVCs can frequently occur in the first few hours post-MI. Heart and lung sounds. These patients can go into early heart failure. You would be concerned about crackles, dependent edema in the lower extremities. Rest. Cardiac rehabilitation. Typically, a lot of patients in this area go to the wellness center, and this is a process of actively assisting the client with cardiac disease to achieve and maintain a vital and productive life within the limitations of heart disease. So when advising the client to exercise gradually and slowly, increase the distance walk. So again, you have to encourage your patients, they need to start slowly and then increase the duration. So vital signs that you would want to teach your patient to monitor to determine whether to increase or decrease their exercise levels is the pulse rate. It's expected to increase with exercise, but it should not increase more than 25 beats per minute above the baseline. So again, educate your patients how to take their pulse. I'm going to skip over the next slide. I'm going to skip over this one. I just want to point out, you know, nitroglycerin, it can also cause hypotension, which is why you always, anytime you give the patient their first nitroglycerin, obviously you've checked baseline vitals, you have a blood pressure. So if that patient's blood pressure is 120, you give it, wait 5 minutes, do a blood pressure. If it's less than 80, then you want to hold that second dose. We talked about morphine sulfate. I just wanted to add that causes pain relief. It can cause respiratory depression, decreased GI motility. It can also cause pinpoint pupils. The patient could hallucinate. Use caution with morphine. Push it slowly in your patients who have COPD. Make sure you're assessing the patient's pain every 5 to 15 minutes. Document the response. Narcan is the antidote. That's given 0 to 0.4 milligrams IV. Talked about beta blockers. I just wanted to add where it says decrease O2 demand, heart rate, blood pressure. So that's a negative chronotrope. So that's going to affect heart rate. Ionotrope, that's strength of contraction or the ability to squeeze with a negative ionotrope. So you want to weaken the heart's contraction to slow the heart rate, which reduces the stress on the heart. Always make sure that you're checking the patient's pulse. Typically with a beta blocker, you're holding it if the patient's pulse is less than 60. So with your thrombolytic agents, again, make sure you're monitoring for black tarry stools. Other things you're going to monitor, PT, PTT, INR, CBC. This can cause bruising as well as bleeding. Lovenox prevents clots from becoming larger or new clots from forming. Side effects obviously would be thrombocytopenia, bruising, bleeding underneath the skin. Antiplatelet agents such as Plavix and aspirin, these prevent platelets from forming together and making clots. They can cause GI upsets. Caution with patients who have a history of GI ulcers. Make sure they take these agents with food. I'm going to skip over the next slide. Angiotensin converting enzymes. Another example would be ramipril or Altase. So for this, it inhibits that RAS activation, so it blocks that conversion of angiotensin 1 to 2, decreases systemic vascular resistance as well as the blood pressure. Again, your side effects, dry happy cough, angioedema, hypotension, dizziness, and remember ACE and ARBs both cause hyperkalemia. So obviously you wouldn't want to give this to a pregnant patient because it can cause fetal kidney malformations. Other drugs, antiarrhythmia drugs, amiodarone, typically given for ventricular tachycardia, VFib, AFib, as well as a flutter. Rapid IV infusion of this can cause hypotension. Cholesterol-lowering drugs, we talked about this last semester, the statins. Be aware of patients' liver enzymes. Typically, you check those at baseline, and then they can be repeated 3 to 6 months after. Watch out for rhabdomyolysis. These break down the skeletal muscles if patients are complaining of um, severe achiness in the legs. Ask them if their urine is orangish red. This can send the patient into acute renal failure. Your stool softeners, like again, you would use these for the opioids. Example would be Colace. So I'm going to skip over the healing process. You guys can read through that. Complications of an MI. So the number one complication a patient can have is dysrhythmias. 80% of MI patients develop this. It's the most common cause of death in the hospital. An interior wall MI. This occurs when the anterior myocardial tissue, usually supplied by the left anterior descending coronary artery, suffers an injury due to the lack of blood supply. This can lead to left ventricular injury, heart failure, shock, and so on. So your EKG findings: ST segment elevation in the anterior leads. So that would be V3 and V4. An ST segment elevation is typically it's a concave downward, and it frequently overwhelms that T wave, and you'll see some pictures of those in other lectures. And that's called tombstoning, because it's similar to a shape of a tombstone. ST segment depression in the inferior leads. The inferior leads on an EKG are leads 2, 3, and AVF. You're not going to need to know that for this quiz, but we'll talk more about that when we talk about dysrhythmias again in the following lecture. And inferior wall myocardial infarction. This occurs when inferior myocardial tissue supplied by the right coronary artery, or the RCA, is injured due to thrombosis of that vessel. So typically your EKG findings would be an ST segment elevation, and inferior leads 2, 3, and AVF. You can also have a reciprocal ST segment depression in the lateral and or the high lateral leads, which would be 1, AVL, V5, V6. Again, you don't need to know that for this quiz. Acute pericarditis, I think we talked about this last semester in 320. It occurs usually 2 to 3 days later. It's inflammation of the visceral and or parietal, the outer pericardium, so that sac becomes inflamed. You often can hear a pericardial friction rub. That's a scratchy, high-pitched sound that's heard on auscultation, and it's produced by the rubbing of the inflamed pericardial layers. Patients can have fever, chills, also an elevated white blood cell. These patients need to be remained in a high Fowler's position, typically treated with NSAIDs and steroids. Dressler syndrome. This is pericarditis with an effusion and fever. This develops 4 to 6 weeks after an MI, also post-CABG. So Dressler syndrome, it's believed to be an immune system response after damage to heart tissue or to the pericardium. Cardiogenic shock. This is failure of the heart to pump inadequately, thereby reducing cardiac output and compromising tissue perfusion. It requires aggressive management of dysrhythmias. Patient may need to have an intra-aortic balloon pump or vasoactive drugs. So the goal of treatment is to maintain tissue oxygenation and perfusion to improve the pumping ability of the heart. I'm going to skip over the next following. You'll learn more about shock in 422, which you guys will have that in the fall semester. One thing I just want to bring up with shock, cardiac output is low enough to cause the cells to experience hypoxia. So the cells switch from aerobic to anaerobic metabolism. And so with anaerobic metabolism, that creates lactic acid accumulation in the blood, and it leads to lactic acidosis, and it must be removed by the blood and broken down by the liver. So the process requires unavailable oxygen. So remember, tissue perfusion is decreased, which is why there's not enough oxygen. Stages of the compensatory stage. The only thing I want to add where it says the baroreceptors and the carotid sinus and aortic arch activate the sympathetic nervous system in response to a low blood pressure. So this will stimulate the sympathetic nervous system to release catecholamines, such as your epinephrine, norepinephrine. So it increases heart rate, blood pressure, and when this occurs, there's increased perfusion to the vital organs. So less blood will go to your non-vital organs, such as the GI tract, the kidneys, the skin, the lungs. It's all going to the heart and the brain. Stages of shock, compensatory. The only thing I want to add, there's decreased blood flow to the kidneys, activates the RAAS. So we talked about this, how renin stimulates angiotensinogen, which creates tensin 1. Angiotensin 1 turns to angiotensin 2. And if you recall, angiotensin 2 is the powerful vasoconstrictor. So the presence of angiotensin 2 will also trigger the release of aldosterone. So it makes the kidneys keep sodium and water. And why does that matter? It's because it will increase the blood volume. So you would expect to see an increase in venous return to the heart, leads to increase in tissue perfusion, and the cells will receive more oxygen. I'm going to skip down a few things below where it says increase in rate and depth of respirations. So if some parts of the lungs are not being perfused, gas exchange is not going to occur in those parts. So you have what is known as a VQ mismatch. And oxygen levels will become low in the blood, and this will lead the patient to hyperventilate. So I'm going to skip over some slides. In the progressive stage, I just wanted to mention for GI, typically you develop ulcers, bleeding, which isn't good because clotting abilities will be affected due to liver hypoxia. Irreversible stage, I just want to mention that it's also known as the refractory stage, and typically all organs will shut down and fail in this case. So with cardiogenic shock precipitating causes, an MI, cardiomyopathy, that can be acute or chronic disorder of the heart muscle, where it says cardiac tamponade. If you recall, a patient has a pericardial effusion. That occurs when the space between the parietal and the visceral layers of the pericardium fills with fluid, which places the client at risk for a tamponade, and accumulation of fluid in the pericardial cavity. A tamponade restricts ventricular filling, and it also causes the cardiac output to drop. So cardiogenic shock, early manifestations, it's similar to acute decompensated heart failure due to neurohormonal activation of the sympathetic nervous system, the RAS, and the antidiuretic hormone. So typically where it says cardiac shock, physical exam, just want to add in with hypotension. Typically the blood pressure is lower than 90 systolic, or it can be 30 millimeters of mercury lower than the client's baseline. Decreased renal perfusion and urinary output, typically less than 30 milliliters per hour. So where it says diagnostic test, as you see there, I mentioned BNP. A normal level of a BNP is less than 100. So I'm turning to my PowerPoint where it talks about hemodynamic monitoring, which you'll learn more about in 422. So drugs to decrease the workload of the heart, diuretics reduce preload. That's also known as left ventricular end diastolic pressure, and that's the amount of ventricular stretch at the end of diastole. So think of it as the heart loading up for the next big squeeze of the ventricles during systole. So the more air you blow into a balloon, the greater stretch you have. Vasodilators to decrease afterload. This is also known as systemic vascular resistance, and that's the amount of resistance the heart must overcome to open the aortic valve and push the blood out into systemic circulation. So I think of this, to get the air out, the balloon must work against that knot after you've tied a knot in it. And I think that's it actually, a couple more points here I wanted to make. Papillary muscle dysfunction. So with this, the papillary muscles are located in the ventricles of the heart. They attach the cuffs of the AV valves via the chordae tendineae, and they contract to prevent inversion or prolapse of the valves on systole. So what are your AV valves? Make sure that you know that. Ventricular aneurysm. That's a defect in the left or right ventricle of the heart. It's usually produced by an infarction. It can be congenital. Typically, the ventricle just becomes dilated. And so our next lecture will be heart failure.